So today's talk is called At a Loss for Words, so Understanding Primary Progressive Aphasias, or PPAs for short. For the objectives here, I should first define this for you. So it's admittedly a pretty complicated topic, and sometimes it doesn't make sense to get bogged down in the details. This talk is generally for most general neurologists and primary care providers. I would just say, we should remember to refer to our speech pathology colleagues for a full language evaluation if there's any kind of hint that there could be a language problem going on. Most neurologists that you refer to are not going to do a full language evaluation. They're quite comprehensive and take quite a bit of time. I want to show you some case examples. I think seeing these and hearing them really is the most helpful. We'll look at some frontotemporal dementia subtypes. So this includes what's called semantic variant, PPA, non-fluent variant, PPA, and then a subset of this, or some people do kind of differentiate these, and they can exist along a spectrum too, something called primary progressive apraxia of speech. And then we'll also look at an Alzheimer's disease subtype, which is more of a logopenic aphasia. So, and then we'll touch a little bit on kind of why it's important to involve your speech language pathologist, even if you didn't at the start. So when we think about these disorders, these are progressive neurodegenerative diseases, just like the other diseases we've discussed. But the initial problem, at least when you can identify it, is language. This describes a clinical syndrome, so it's not specific to the underlying cause. But usually we see certain patterns emerge from the different subtypes. This does not include patients that have a dementia syndrome and then develop language problems later. That's just progression of their disease into the language areas. And I will admit, this can be tricky to know exactly which symptoms came first. And if symptoms are like language and memory right at the same time, that might be helpful. But sometimes it depends on how you ask the questions, right? When we look at the subtypes of these, so even cognitive and behavioral neurologists find this topic challenging. I know it took me a number of months and actually seeing cases before I felt more comfortable, and I still require assistance from my speech path colleagues. Part of that's because the incidence is low. We don't see a whole lot of these cases. In our specialized memory clinic, we probably see way more than the average clinic. But detailed language time, testing is time consuming. So that, for the purpose of this talk, I don't really expect most of the folks seeing these patients to differentiate between these subtypes, but being able to recognize them is what the key here is of being able to refer them to, a speech language pathologist and ultimately to a specialist if needed. So that's kind of where, what does the workup look like for these folks? Well, you do want to get detailed neuropsychologic testing these folks because a cognitive screener might not be sensitive enough. And even if they do have language as their primary complaint, it actually ends up being multi-domain in a lot of cases. If you do more detailed testing, you'd want to get a brain MRI. You want to make sure you're not missing some sort of tumor or stroke, or sometimes we see asymmetry where the left hemisphere or the language hemisphere is undergoing shrinkage early on. And then a speech therapist or speech pathologist is usually recommended here. And then if we're dealing with certainly a PPA, that's where a specialty referral makes sense. So when we ask about these, these cognitive questions, these cognitive domains, there's always, a whole host of questions we can ask, but we're focusing really more on the language domain in these patients, right? So are they having difficulty naming objects, expressing themselves, getting the words out that they want to say? Is their speech halting or hesitant? Is it really slowed? Sometimes I'll even have a family member show me a text message or an email, is the grammar, has there been a major change in these things? When you do a focused speech exam, so I'm pretty brief in my exams, even in a cognitive behavioral neurology clinic, but ultimately you want to hear what does their speech sound like, and obviously you want to know, is that a change from their baseline? But not all of speech is, it equals language. So there's also the motor production part of it, right? And it requires your brain to plan what you want to say before you say it. So there's a motor, speech, and execution component to this too. And we can test that a little bit. So there's the classic alternating motion rates where we say pa and then ta and then ka, and then we have them kind of pair those together like padaka, padaka, padaka. And so that's kind of where you have them repeat that multiple times. And are they sounding the same with each time? But there's also the repetition of multiple syllables. And this is where I find it extremely helpful, especially for the next case we'll see. And that's where if you add more syllables to the words, are they really struggling with segmenting those words? So you'll see that in the case here. So this is a 80-year-old female with a 3-year history of cognitive concerns. So she's having difficulty getting her words out. She's got a slowed rate of speech, which is a change for her. Sometimes she even alternates her yeses and nos. So she might even nod no while she says yes. She's got no issues with spelling or reading or other cognitive concerns. And she's seen multiple different providers without any clear diagnosis. And even one of them suggested it was a functional speech disorder. On exam, she scores pretty well on her cognitive testing. She's 33 out of 38 with no specific pattern of abnormalities. And on her language exam, so you do note that she's got this slowed and somewhat distorted speech. And what really was highlighted is once she got to like catastrophe and had to say that multiple times in a row, that was more inconsistent and she struggled with it. On the rest of her neurologic exam, it's pretty normal, except for maybe just a little bit of mild slowing when you test her eye movements. So I'm going to move this over. This is a shared file here where it's just out on the internet and it's shared by our speech path colleagues at Mayo Clinic. So this is a case that was seen, and I'm going to try to play this. Hopefully this will come through.
Catnip, 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 catapult, 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 catastrophe, catastrophe, catastrophe.
But that early visit, right, she's struggling a little bit with the catastrophe part. Now this is 2 years later. So this is oftentimes something that becomes more apparent with time as most of these diseases.
Nip, catnip, catnip, catapult, 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 catastrophe, 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 catnip, catnip, catnip.
I'm going to go ahead and pause it there, but you can see that especially as the disease progresses, even the shortened syllables start to become more problematic, but it was only really apparent early on when we were able to get to longer syllables. So what is this case showing us? Well, this is actually a presentation that is not readily recognized even by some of our kind of experts in the field. This is if we want to describe this a little bit better, right, we could say this is a progressive speech disorder. She actually has normal to only very mild cognitive impairment, so that's not the main feature here. She's got moderate speech impairment, so her ability to produce speech is much more impaired than her language skills. She doesn't have any other motor symptoms at this point. And I think at least thinking this way helps you sort of focus on what are we targeting first, right? So we need to have her see speech therapy, right? When she can slow down her syllables and things, she can get out the words she wants to say, especially early on. But she kind of needs some of that therapy to help with. And so this actually, had an MRI scan. I'm not going to show it to you in the interest of time, but it was pretty normal. But when we got a PET scan of the brain, it kind of told us what was going on. This is a pretty minimally affected PET scan. This is measuring glucose metabolism. We've shown you some of these cases, or, these types of scans in prior lectures. But the areas that are gray are normal. And you can see this kind of hot red spot and then another spot here, kind of right over the left side of the brain and kind of right where the pre-motor or what we call the supplementary motor area is. So in order for your your motor cortex, see mine just flared up there, but for your motor cortex to tell your mouth how to produce the speech, there's a premotor area that basically instructs that. And that's where her problem is. And so her speech production is what's affected. And this is what we see in patients with primary progressive apraxia of speech. These individuals, so there's just kind of the highlights of what we see in these folks. So the motor planning signals to direct muscles related to speech are affected. And this can start to involve non-speech oral apraxia. So they might struggle to click their tongue, or if you ask them to cough, they might just say cough. They might not actually be able to do it spontaneous or to do it on command, but they could still cough reflexively. Which this can start to involve swallowing difficulties over time. They can have slow overall speech rate with kind of hesitations. And then you've seen this example of the variable syllable segmentations. They will tend to reverse their yeses and nos, which is kind of interesting. And these patients can be along a continuum of the non-fluent variant, which really starts to involve more of Broca's area, which is sort of that we classically think of as sort of getting the words out that you want to say. So I'm going to show you a different case that highlights that one a little bit more. When we look at these cases over time, Mayo Clinic has the best sort of longitudinal studies in this subgroup and even has autopsy data. So we know most of these patients are due to more of a frontotemporal dementia protein, or our tau. And if you follow folks for over 5 years, about 40% of them will evolve to these sort of progressive supranuclear palsy or cortical basal syndrome type cases. And so I'm not going to go into these in full detail, but you can see how PSP, there's a lot of overlap with the area involved in some patients, but these folks then start to have a lot of instability and falls and Parkinsonism. And so these are usually referred to as Parkinson's plus syndromes. So yeah, that's kind of how some of these cases evolve, but not everyone does. So we need better data to kind of figure out who's going to progress. But that's one of the key things. Hey, we need to be monitoring for your balance and motor symptoms, right? If somebody has one of these diagnoses. All right, so this is a slightly different case, 74-year-old with 2 years of troubles getting my words out. He's leaving out connecting words and text messages and speech. And these are kind of simple fragmented sentences. Also struggling with other cognitive aspects, so not able to multitask, struggling with some motor skills, so playing the piano, buttoning shirts. On cognitive testing, scores in sort of a mild dementia range. There is quite a slowed rate of speech, similar to our last patients, but and they're able to repeat simple words. They can name things, and on their neuro exam, they're just having some mild difficulties with more complex motor movements, more on the right side of their body. All right, so I'm going to show you a video here. This is from our neurology continuum videos.
And why are you here? What kind of difficulty have you been having?
Well, I not say the words and numbers, or write down the words, and the reading. I can't say the words, and if I the reading, but I go back to the words, and yeah.
Okay.
Yeah.
And so if she's
Tell me what's happening.
kind of normal in conversation, other ways to show them a picture and have them kind of try to explain what they're seeing to see if you are getting sort of those more fluent sentences or not. So,
Yeah.
Tell me what's happening in the picture and try to talk in sentences, all right?
Okay. The family is going outside of the house, and the girl is putting sand in the castle, and the mother and dad is picnicking, and the wind is blowing up the flag. The radio is probably music.
I think that last example there is sort of a good one where really is more of these short segmented sentences where you kind of lose some of the connecting words of a normal full sentence. And so if we kind of go to our handy dandy sort of clinical criteria for these kind of three main different progressive aphasia syndromes, the one here on the left fits best, where it's sort of an effortful, halting speech, and then sort of missing these connecting words. So the oftentimes these patients can name things for you without any difficulty. So their comprehension and object knowledge is retained, but their overall speech, there's just missing words there. And so when we look at these types of cases, here's an example of someone with a PET scan where similar areas to our progressive apraxia of speech patient, right? But you're getting a lot more involvement. And then certainly down into, on the left side of the brain, the sort of Broca's area, what we call the inferior frontal gyrus. All right, last case here. So this is a 52-year-old with 2 years of cognitive concerns. So they're kind of generic cognitive concerns, but they're gradually getting worse. You note that when you're kind of doing your history, his speech is fluent, but he's continually using this and that to describe things rather than kind of being specific with what he's talking about. And the spouse also suggests that she's seen this as well. On Montreal Cognitive Assessment, so he scores pretty well, 25 out of 30. It's kind of right around that borderline normal range. But where is he missing points? It's on naming. So when you have him try to name these animals, this is what he says. He says, this is a cat, we've got a hippo, and then a camel. And then we do a more detailed naming test. He's scoring in quite an abnormal range. He struggles to define things like what is an island or what is a periscope. Whereas, repetition and speech motor production is normal. And so this is what one of those cases might look like.
Well, there's a woman and a guy sitting together. Both appear to be on the verge of drinking something. There's a boy with a dog running after him who's got a flower thing, not a flower thing, I don't know what the hell you call that. That's one of those things I keep forgetting. There's a guy over there who's evidently catching a fish. There's a boat out on the water. There's another girl having fun playing with something near the water. Yacht, guide, Achi, death, knife.
Turn the page.
Bergen, laughter, biscuit. Pen?
No,
No,
not
not
pen.
a pen.
Now hold it in your hand. Does that help?
I used them all the time.
Mm-hmm. called scur.
Scurvy? No,
And so what you saw there is, so one thing that they did is kind of evaluated the what we call surface dyslexia, or kind of irregular words where, yacht was pronounced as yacht. So they might lose that surface dyslexia type of thing. And then also on the detailed picture, so there was complete sentences, but the girl's playing with something. The kite was called a flower thing, right? So they're kind of losing this ability to name things appropriately. All right, so when we kind of go to our core features here, the one that fits best with this is there's impaired single word comprehension. What do things mean? But also when you try to have them name things, so there's impaired confrontation naming. What is this called, right? And where in the brain does this show abnormalities? This is a case of this semantic variant primary progressive aphasia, and it's right in the anterior temporal lobe on the left side of the brain, which is right where your kind of naming center of the brain is. We call it kind of our semantic word knowledge area. And so most cases of semantic dementia in general are language variants, and they tend to involve significant difficulties with naming things. So like a classic, what is a filter, right? Rather than the behavioral variant, maybe more of where is my filter? Where is my spouse's filter, right? Nouns can often be more difficult early on. So instead of saying, where's the toothbrush, they might describe what it is they're looking for. And they'll also have reduced semantic specificity. So calling the dog just an animal or the gorilla a monkey, in that way. And then you can have behavioral symptoms in these patients, but that's usually more once the right side of the brain gets involved. You can see it's very minimal in this case at this stage, but here's a case where we had severe left side involvement, but also the right side getting significantly involved here. This patient had a lot more behavioral symptoms. Now, this can present on the right side. It just usually goes unrecognized for many years until the left side starts to get involved. But patients may have behavioral changes for many years before they get a diagnosis. So a word on logopenic aphasia, that's the one we haven't talked about here in the middle. And this one is actually due more to, in like 90+% of cases is due to Alzheimer's disease rather than those previous ones I've showed you due more to frontotemporal disease. They may struggle. I had someone describe it as like their internal tape recorder is gone. So like what someone just said, if I need to repeat that back, I quickly lose it. So a classic thing like a phone number, or on our MOCA exam, we literally do this. We say, repeat the cat always hid under the couch when the dog entered the room. And they really struggle with this. They might miss pieces of this sentence when they try to repeat it back to you. Now, their rate of speech is generally normal until they run into word finding difficulties. So they're often searching for words in the middle of conversation. They'll lose their train of thought, mid-sentence. Most of these folks evolved to have memory symptoms as well, which kind of supports the involvement of Alzheimer's pathology. And where we see this, obviously on the left side of the brain, it actually overlaps quite well with the typical language network, which involves this temporoparietal junction. And these cases are almost always due to, we see pathology in amyloid and tau, which is Alzheimer's disease. These folks in particular, and I would say for most of the primary progressive aphasias, especially if anxiety is one of the symptoms that's present, SSRI, specifically escitalopram and sertraline, can help with that, because this can create a worry loop. And if they're kind of worrying throughout this, I can't find the word in the middle of conversation, then that's going to further block speech production. In logopenic specifically, we do use donepezil, so that can help with some of the symptoms. But the other thing to think about, why is it important to make a diagnosis here? Some of these patients may be eligible for the anti-amyloid medications, whereas the frontotemporal subtypes that don't have amyloid involved, they would obviously not be candidates. speech therapy should be initiated in all of these types of cases. And there are concerns of low referral rates for this. I do think that, just think of it this way, right? If you had a patient with balance problems, you would refer them to physical therapy, or hopefully you would. And the same should go to someone with speech related problems. Um, and I would argue most of this is probably just due to under recognition of these disorders. But I do think that referral is really helpful, because when you look at the data, so like 78% of patients that get a diagnosis, even if they do get a diagnosis of PPA, they experience barriers to accessing speech and language therapy. The potential benefits there are, can we facilitate communication strategies through other methods? Can we record things if we know this is going to be something that's going to get worse? Can we have soundboards and things like that, or picture boards of things that we commonly use, especially at later stages? There's a lot of benefit for families to kind of understand what is going on, because this is a pretty rare disorder. And the overall goal being to maximize overall quality of life here. All right, so hopefully we met some of the criteria. I wanted to at least show you some of these variants and how they present. I think specifically the one that often gets missed is the slow rate of speech patients. But all of these, when you have just kind of a progressive language disorder, be aware of kind of what that workup looks like, and then refer to a speech and language pathologist if that seems to be what's going on, or at the very least to try to help you sort out, is this a language problem or not? And I would say for some of these folks, especially the ones that exist along this apraxia of speech and the agrammatic or non-fluent variant, these folks tend to progress to involve Parkinsonism, and almost the majority of patients, at least 40% of them. So being mindful of that and referring to PTOT would be reasonable. All right, I'm going to